Hello, good morning, good afternoon, good evening. Welcome to our Symposium for Health Systems Research 2020, focusing on governance and the impact of COVID-19 in Argentina, Brazil, Costa Rica, Chile, and Ecuador. We will be discussing research that we were conducting during the pandemic and for which we drafted an article that is currently under review. I am Irene Torres. We will also be joined by Cristina Alonso, Cristiani Vieira Machado, Osvaldo Artaza, and Rocio Sáenz. Next, please. Yes, if you are still having issues with tips of using the platform, you can see here the brief instructions that you need to have a good viewing experience with us today. Otherwise, you can also contact the support chat. Thank you. So as chair of the symposium, I will give a brief introduction, and then I will introduce the rest of the presenters. I am from Ecuador. I belong to Fundación Octaedro and also to the Rockefeller Foundation, Boston University Commission on Health Determinants, Data, and Decision Making. Next, please. Great. So to give you a brief overview of the panorama in these 5 particular countries of Latin America, I can tell you that there is a systemic weak governance in the region, and in particular in these 5 countries. There is also much corruption in the public sector in general and the public health sector in particular that has throughout the years strengthened the private sector. Each country will explain what the involvement of the private sector in health is. But this is generally speaking the situation. Also, there's a large informal labor market in Latin America. In average, 50% of all work is informal in the region. And this had implications for the response to the COVID-19 pandemic with national lockdowns, for example. Also, because of the pandemic and also because of reasons prior to the pandemic, it is estimated that 231 million people in America will be living in poverty by the end of 2020. This was recently cited a few days ago in a Lancet editorial by Richard Horton on a humanitarian crisis, a real humanitarian crisis we are living in the region right now due to the pandemic, and again, due to causes prior to the pandemic. In general, in average, 34% of total health spending in the region is out of pocket. This means 1/3 of total health spending. Next, please. If you want to understand the slice of cases, of COVID cases in the region compared to other countries, you can see here a timeline of the percentage of total cases that occupy, that are in Latin America, are located in Latin America. This is a Financial Times graphic where you can see also how it grew towards June and July. And it has diminished, but we are experiencing now different outbreaks. So we are still waiting for the final, let's say, outcome. Next, please. So in this study, we analyzed 3 different dimensions of governance: institutional, which focused on government leadership and credibility; decentralization of decisions and also measures; and the inclusion of civil society, where the civil society was included in decision-making and also implementation. Next, please. And the operational dimension, which includes intersectoral coordination, the inclusion of minorities, and also consultation with experts and other groups, including community or non-governmental organizations. And finally, the informational dimension of governments regarding the use of scientific evidence and transparency on data and decision making, which is a dimension that we are using from environmental theory. Next, please. So now we have Cristina Alonso, who will discuss the results on Argentina. Thank you, Cristina. Go ahead. You have to unmute.
Thank you, Irene. Good morning, everybody. I will be discussing the governance response of COVID-19 in Argentina. Just to situate you in Argentina, Argentina is a federalized nation in the southern cone of Latin America. It has a very urban population, most of which are centered in the area of Buenos Aires. And it has a total population of 45 million. Most of them are distributed in the urban center of the capital and kind of towards the north. The south is very low populated. Argentina has a high healthcare spending. It does have a universal healthcare system. However, a lot of additional spending comes out of pocket due to quality issues. And this has led to a fragmented healthcare system. Although it is a federal country where decisions are centralized, this also doesn't allow for local nuance, and it certainly doesn't include cultural nuance. It's a very disequal country with a Gini coefficient of almost 40%. So this really speaks to high levels of vulnerability and high levels of wealth that aren't being distributed. And we know that 49% of the population were already having financial difficulties before the pandemic. So this pretty much set up a financial or an economic situation where due to a serious lack of wealth accumulation among the majority of the population, the pandemic hit really hard. So Argentina actually takes the prize for the first COVID case in Latin America. The first COVID case was reported on March 3rd in Argentina. And in fact, the first death in Latin America also occurred in Argentina, also at the beginning of March. Quickly, the government responded, and on March 12th, it declared a national health emergency, and it declared a strict lockdown on March 19th. And this lockdown was originally established for a month, and then it was extended, and then it was extended, and then it was extended. It was extended several times until July 17th, which doesn't mean that on July 17th, it was disbanded and people were allowed to walk around. There's been different iterations of the amount of sort of social freedom, I want to call it, that people have been able to have. But really, Argentina has, it definitely first was noted in the literature as a positive thing that Argentina had, locked everything down and making sure that everybody was staying at home. Over time, because of the extent of the lockdown, Argentina has had the longest lockdown. Critiques have come up about human rights violations, about reminiscence of the military dictatorship, and just questions about how, when we balance economics and safety, how relevant is it to actually have such a strict lockdown for such a long time. Argentina focused on a hospital-based response, and we'll see this in several countries in Latin America where the guidance is given by physicians instead of public health experts, and where the priority is put into building ICU units. So it's really kind of very downstream, taking care of the people that can't breathe, that are needed to be intubated, over a public health response. So on May 1st, 12 emergency hospitals were completed. This allowed for 12,000 new beds to enable people that needed to be hospitalized to be able to access those services. Then on July 18th, a plan was announced to relax social distancing measures. However, this was not so relevant in the urban center of Buenos Aires, where the quarantine has extended until October 25th, with different levels of opening and closing depending on, depending on how dense the population is. Obviously, in more rural areas, the quarantine was lifted. In more densely populated areas, the quarantine has extended. This has had tremendous economic implications, which I will get to in a minute. But we do see that despite this very strict lockdown and quarantine, Argentina won another first prize, which was that it reached the highest positivity rate, reaching 60% in October on October 5th, which speaks both to a lot of people getting infected and also not a lot of people getting tested. And we'll see this more in the Costa Rica example, where high positivity rate might be a good thing if you're targeting adequately, but it also just might mean that a lot of people are getting COVID. So just to break down the national governance and strategies, if we look at institutional governance, Argentina had a strong initial institutional government. So this was the strict quarantine, the strict lockdown. They implemented an international travel ban, and national travel was restricted. In-person education was immediately suspended as well. However, when we start looking into the more, into participation and civil society, we're going to see that the Ministry of Health really relied on virologists. And if we look at their, at their informational governance, they did report daily on cases. But again, this tended to be from a very virologist point of view, how many cases, how many deaths, without really looking at a larger picture of how public health was doing, and again, how the economic situation of the country was doing. There was systematic testing of suspected positive cases, and actually it got to the point where people who had been in contact with positive cases were assumed positive. From a economic perspective, to protect workers, there was a no firing decree that was issued on April 1st, and this was extended until October 23rd, which meant that any company that was, any company could not fire a worker because the company was, going into bankruptcy. There was sort of like this, we had to keep workers employed. However, in the context of Latin America, as Irene said at the beginning, where over 50% of workers are informal workers, this leaves 50% of workers unprotected and vulnerable to the economic catastrophe of COVID. So for this, on May 11th, $5.6 billion were added to the public spending budget for financial support of population. This is a country that has struggled with economic debt, with, continuous recessions over the years. And so a 5.6 billion additional budget it's very serious for the government. So from mid-July on, once the quarantine was relaxed a little bit, a lot of the focus was on economic survival and economic cushioning. So 39 million was dispersed into loans into small and medium businesses. Again, reflecting the support of formal employees, but putting informal employees at risk, again, for increased vulnerability. So as a consequence, we've seen that poverty has risen almost 41% in Argentina. The economic impact of COVID has been brutal because, of course, first you have the economic impact of COVID itself added to this very long lockdown that has really crippled the economic aspects of society. Added to this, on an operational level, there's been weak testing, very weak contact tracing, and very weak public outreach. So, on one hand, you do have additional hospitals, but the public health system to protect people from actually getting COVID, other than being stuck in their house, is virtually non-existent. In addition, just to really kind of go into how Argentina is making decisions, it's not including civil society, it's not including community organizations, and it's not including vulnerable populations, which we'll see as a continuous theme among the region. But it also means that decisions and outreach can be very irrelevant to certain populations. So just to give you a sense of the numbers, the WHO really prided Argentina on how the lockdown had helped to flatten the curve, but the lockdown became economically unsustainable, and just public pressure urged the government to open things up. People started violating the quarantine, and we're seeing cases just skyrocket. And right now, Argentina is one of the highest numbers of cases in Latin America. So, in conclusion, what are we learning from Argentina? We're learning that initially institutional government was strong. So this early response, national lockdown, it flattened the curve, it saved lives, it was great, but it was too much. So we can almost say that the institutional governance was too strong. And this ultimately led to a backlash and a weakening of institutional governance. And there has been critique in the human rights literature that Argentina was on the verge of a state of siege without actually declaring one, and that this was a violation of constitutional rights. What was happening was that there was a concentration of powers in the hands of the executive. Constitutional rights were limited. People could not assemble. There was a militarization of the public space. And this is very reminiscent of other moments when Argentina has gone into a state of siege, both in the early 2000s and also from the military dictatorship. So this put, lawyers, public health activists, other people started to become concerned about how, what did this institutional governance, what did all of this insistence on lockdown, what was it actually trying to do? So in the end, it was weakened because it undermined the credibility of the government, and it started to raise some very important questions on why are we on lockdown when poverty rates are rising so much. From the perspective of operational and informational governments, we see that across the board it's generally weak. There was, and this we see in the public pressure to reopen so that the economic sector could continue to generate income for people, especially those involved in the informal sector. And this, of course, led to a massive increase of cases and deaths, which means that Argentina was really not taking a public health response to it. It was just waiting for people to get sick and hoping that they wouldn't get sick because they weren't having contact with each other. And added to this, if you have a universal healthcare system that's fragmented, that's inefficient, where people are coming up with a significant proportion of the costs out of pocket and very little involvement of civil societies and vulnerable groups, we're seeing that COVID itself is continuing to fragment an already weakened system in a country that's been on the verge of economic collapse for many years. So thank you. And I will pass it back to Irene to introduce Cristiani.
Thank you, Cristina. That was excellent. Thank you very much. Now we're going to learn from Cristiani Vieira Machado from Osvaldo Cruz Foundation, known as Fiocruz, the Sergio Aroca National School of Public Health. Thank you, Cristiani, for joining us today.
Thank you. Good morning, good afternoon, good evening to everyone. It's a pleasure to be here in this panel. I'll talk a little bit about the Brazilian experience dealing with the COVID-19 pandemic. Next, please. First of all, it's important to highlight that Brazil is a very huge country with more than 200 million inhabitants. It's a federation which comprises 26 states, a federal district, and more than 5,000 municipalities. It's also marked by deep economic and social inequalities that express themselves in terms of income, race, and gender. On the other hand, since 1988, we have a new constitution which recognized health as a right of citizenship and a state duty, and also created the Unified Health System, the SUS, which is a universal, public, and very comprehensive health system. Nevertheless, at least since the 60s, we have a very important private sector in the country as well, which is very dynamic and subsidized by the states and involves private health insurance, private health plans. And this sector has been growing in the last 30 years parallel to the SUS. Since 2015, we are in the middle of a very important political, economic, and social crisis. We suffered a presidential impeachment in 2016, which was supported by economic elites. And in 2019, a new government, a very right-wing government, took office after national elections. Since 2015 and after the impeachment, we have been through several conservative and neoliberal reforms which are affecting social policies and also the public health system. Next, please. In what regards the COVID-19 pandemic in Brazil, the first reported case was in February the 26th. The first cases were imported, and by the beginning of the March, it was announced that we already had community transmission. The disease initially spread from big cities, internationally connected and high-income groups, to middle and small towns and to more vulnerable groups. We observed diverse territorial dynamics, as Brazil is a very big and heterogeneous country. And for example, there was one kind of a dynamic in metropolitan regions, and in the Amazon region, it was totally different. The disease went up the rivers to reach indigenous populations. It's important to say that we had a potential strength to face the pandemic, that was the existence of a public universal system, the SUS, which has a very important tradition in epidemiological surveillance, in health information systems, and also has a very expressive primary healthcare coverage nationwide through a family health program. Nevertheless, after 8 months of the pandemic, we had more than 5 million confirmed cases. We are the third in the world in total number of cases, and more than 150,000 deaths reported. We're the second one in reported deaths. Now we have already more than 160,000 deaths reported. We also observed high lethality levels, especially among the most vulnerable, among the elderly, the poor, Black and indigenous populations. We also had high mortality levels among health professionals and many avoidable maternal deaths due to COVID-19. Next, please. As you can see in this figure, Brazil presented, comparing to other selected countries, high incidence and also high mortality levels. Now we can see that by the end of October, it was the second country with the highest mortality level, and very close to Chile here. Next, please. Oh, the previous one. Yeah. In what regards national governance and strategies, we had two different phases. From February to mid-April, we had some initiatives of closure of borders, economic and social measures, although some of them were late, poorly coordinated, and insufficient. The president of the Republic had a position against social distance, so the adoption of physical distance measures and lockdown was dependent on the state and municipal initiatives. There were, for sure, some coordination efforts by the Minister of Health with daily public reports and press interviews. Since the beginning, in what regards the health system, there was an emphasis on hospital care. There were investments in opening new hospital beds in new emergency hospitals as well, but there were many difficulties in importing supplies and equipments. It was also very important to remark that there was, since the beginning, insufficient tests, despite increasing national production of diagnosed kits, including by Oswaldo Cruz Foundation, which is my institution, which is a federal research institution in the area of health. From mid-April on, the conflicts between the president, the health authorities, and health experts became stronger, became more intense, and there were two changes of Minister of Health. The president's interference in health strategies also grew, and he gave many declarations not based on scientific evidence, for instance, against social distance, and also defending the use of chloroquine despite the lack of scientific evidence. Public communication and official information became more unstable, especially on what regards testing and on incidence and mortality levels among more vulnerable groups. From July on, there was another change in context. All the attentions became to be directed to the search of a vaccine. The federal government is indeed investing on the search of a vaccine, and the Oswaldo Cruz Foundation, which is my institution, is preparing itself to produce the vaccine. We had this agreement with the Oxford and AstraZeneca vaccine to produce it in Brazil. But also there emerged some new controversies regarding the vaccine and new federative conflicts, especially between the presidency and the state of São Paulo governor. Next one, please. What, the previous one? Okay, thank you. In summary, the national response to COVID-19 pandemic in Brazil was hampered by poor intersectoral and federative coordination between the three government levels, political decisions not based on scientific evidence, resistance to adopt more restrictive social distance measures, and lockdown by governments. And after some time, the municipalities and states that had adopted some measures suspended them while the cases were still very high, low priority to the primary healthcare role, insufficient testing and contact tracing, and insufficient provision of critical supplies and equipment, in part because of the high dependence on imports. We shall say also that negative outcomes such as high mortality rates and adverse social effects can also be explained by structural inequalities, previous economic and social vulnerabilities, and also low investments in the public health system. As a lesson, we can say that the pandemic makes clear that it's essential to strengthen the universal health system, the SUS, to invest on national science, technology, and innovation in health, and to adopt integrated economic and social policies to overcome the current crisis and also to reduce inequalities in the short, medium, and long term. That's it. Thank you very much. I'm available to additional questions.
Oh, sorry. Thank you, Cristiane. You were very fast. I remind our public today that you can ask questions in the forum, the open forum that is available. I've only seen one question so far, so please feel free to ask questions to be addressed later or at the end of the session. Thank you. So our next presenter is Osvaldo Artaza from Chile. Osvaldo is a former Minister of Health of Chile. He has a Master in Health Administration. He's also a pediatrician. And he's currently the Dean of the Faculty of Health and Social Sciences of the University of the Americas in Santiago de Chile. Thank you, Osvaldo, for joining us today. And we're looking forward to hearing about your results and analysis.
Hello, many greetings to all from Chile. Chile is a country located in the southern cone of Latin America with 18 million inhabitants. Before the pandemic, it had a high human development index. Just 8% of the population living in poverty. Life expectancy of 80 years and an infant mortality rate of 7 per 1,000 live births. However, it is a very unequal country. The Gini income distribution index is 46.6% due to a high concentration of wealth with insufficient public spending on health, just 4.2 of gross domestic product, and a high out-of-pocket expense. Next, please. Thank you. Chile has, since the health reform in the military dictatorship period, has a segmented and inequitable health system in which the high-income population is insured in private health insurance and access high-quality private providers, and about 18% of the remaining population access to limited and fragmented public service. Fragmented since the National Health Service, created in the years 1952, was divided during the dictatorship into 29 regional hospital networks, where the first level of care is administered separately by the municipalities, 345 municipalities, local governments, making governance and networking very complex. Next, please. In Chile, once democracy has been recovered in the year 1990, this is the year, after a long military dictatorship, maintaining the constitution and the neoliberal development model of the dictatorship, there has been, after 50 years, an economic development that has not resolved deep inequality. Citizens tired of abuses and privilege of the elite were losing confidence in authorities and institutions, generating a social and political crisis of unprecedented dimension that erupted on October 19 in the recently last year. Social revolt that is only interrupted by the pandemic. Next, please. To date, Chile has become one of the countries with the highest mortality per million inhabitants. Next, please. The Chilean response was mediated by a context of deep social, political instability. Citizen response was characterized by a loss of confidence and credibility in public institutions and authority, and insufficient adherence to the prevention measures, which was determined mainly by a governance crisis and economic or subsistence needs. Please, the next one. Thank you. The number of infection and death has affected sectors, municipalities, with a higher proportion of families in multidimensional poverty, almost 3 times more than in those where families with higher incomes are concentrated. Next, please. Chile had a poor ability of the government to give governance to a fast and effective response. The pandemic highlights key aspects in the field of governance that we must consider and that can explain our failures. In the field of health service response, Chile opted for partial lockdowns that changed over time and were limited to certain municipalities. The first case was officially reported on the 3rd of March this year, and on March 18, the borders are closed, entering in those days without sanitary control many travelers returning from vacation in Europe. The response emphasized increasing the number of tests for symptomatic people who consulted hospital and increasing critical care beds and the number of ventilators. Until now, testing, contact tracing, and isolation have not been prioritized, with primary care not receiving additional resources or being given a leading role from the onset. Unfortunately, in Chile, care services are disintegrated and primary health care strategy continues in the fact to be invisible for current health authorities, given the prevailing biomedical and hospital-centric paradigm existing in the ruling elites. This results in the loss of valuable expertise at primary health care level, making it difficult to act in an integrated way with the community and in the territories. Next, please. No, next. Next, yes. In the field, no. Yes, in the field of social protection and population response, we observed a tendency in the government to prioritize economic matters over the health of the population. The neoliberal economic model generates important cultural change in Chilean society in the order of more individualistic behaviors that did not facilitate attitudes of cooperation, capacity of people to act in an organized and disciplined way, and the search for the common good. The level of social inequality, the weight of the social determinants of health, and the insufficient, ineffective, and late social protection measures that would support family and most vulnerable groups during the lockdown. Next, please. Next. Yes, thank you. In the field of information and communication, multiple spokespersons have consistently provided dissenting opinions, and government communication were questioned as erratic, unreliable, and flawed. Likewise, lack of transparency in access to information, quality of information available for decision making, and change in the criteria for counting case and deaths were constantly questioned by scientific society, exacerbating lack of confidence and credibility, which escalate, leading to a change in the Minister of Health. In mid-March, the Ministry of Health formed an advisory council for the pandemic, made up of renowned specialists. Following public confrontation between the government, mayors, and civil society organizations, a COVID social council was formed. Both entities, on several occasions, said publicly that their recommendations and opinions were not heard by the authority. Next, the final one, please. Thank you. Without a doubt, the pandemic has exposed our current weaknesses, and these weaknesses are translated into many deaths that could have been avoided. Along with many changes that our people demand, important changes in our health system are urgent, as well as great transformation in the global health field. We need to learn about the lesson for better governance in health. For this, it is key to build a new social pact in Chile that enables trust in institutions and the ability to act together. Chile has just approved by a plebiscite the beginning of a process for a new constitution, which can open possibility to build a new social pact that contributes to better governance in the face of health crisis, such as the one we are experiencing today. Thank you very much.
Thank you, Osvaldo. Thank you so much. We have an unforeseen circumstance, and Cristiani will leave us earlier than the end of the panel. And there is a question in the chat regarding federalism in comparison to unitarian state governance. And I asked Rocio if we could give some minutes to Cristiani to please explain that to the audience before she has to leave us today. Cristiani, are you there? I hope the host can help us unmute Cristiani so she can share her microphone and video. Wait, Cristiana, you're not unmuted. No, we can't hear you.
Okay, can you hear me now? Can
Perfect,
you hear
thank
me
you.
now?
Go ahead.
Okay,
Yeah.
thank you. I'm sorry about that. There is a button here. And that is a very interesting question indeed, because Brazil is a federal country, and we do have federative councils in the health sector. We have councils that put together the Minister of Health, the state secretaries of health, and also representatives from the municipalities. The municipalities have a very strong role in the healthcare system, but they are represented in those councils that we call the tripartite councils that reunite the three levels of government. So there was this potential to coordinate the national response through those councils, which are very important in the trajectory of the unified health system. Nevertheless, they were not the main locus of a decision in the pandemic. The decisions were more centralized in the federal government. Initially, there were some important coordination strategies. There were this national committee, which was coordinated by the Minister of Health, and there were states and municipal representatives as well. And but this was not sufficient. And after the crisis, the political institutional crisis became more evident, the intergovernmental coordination became worse. There was also this resistance by the federal government to adopt national measures of social distance recommendations, and so they were adopted different by the different Brazilian states and by some municipal governments, but not by others, and they were adopted in different moments. Sometimes the situation was already very severe and they were suspended when the cases were still high, and so the federative coordination was really poor, and that was a pity because the SUS has some special committees for that. In what regards social participation as well, we have in the health sector some participatory councils at the three government levels, the health councils with representatives from the civil society, but they were not valued during the response. Their role was not so important as it should be. And so that was mainly what happened, unfortunately.
Thank you so much, Cristiane. We are now going to hear from Costa Rica. Great. Thank you, Cristina. Great. So Rocio Saez is also a former Ministry of Health, but in the country of Costa Rica. She's a physician and also has a master's degree in public health. Thank you, Rocio, for joining us.
Thank you to be here. Is really a pleasure with the partners in this panel. Let's go to the first slides, please. We want to share with you a general information from Costa Rica. We are a very small country in Central America. Our population is around 5 million. We are a high middle income country. And it's important to let you know that before the pandemic, the country faces a performance of productive structure does not generate enough jobs or adequate quality. During the pandemic context, in the third quarter of 2020, the employment rates reached to 22%. The unemployment rate grew 10.7% points compared with the third quarter of the 2019, and the workforce decreased by 74,000 people compared with the year before at the same time. And for me, it's very important to capture your attention that the most important impact was in women. The greatest weight fall, especially in the women. And for that, we are very concerned about this social impact of the pandemic. The informal employment is around 44%, and our Gini is around in the middle. This is no good for us, which we like and we want, and before 10 years before we stay in better position. For that, it's clear that our inequalities is increasing. In the right part of the slide, you have some information for our INEC, that it is the statistic institution, and only to show the different poverty and extreme poverty during this time in Costa Rica. Next, please. Also, of course, like many other countries in Costa Rica, we are in high transition demographic. Our life expectancy is around 80 years, 81, 82 years. The good news is we are the winners, the women, and the number of years between the women and the men is around 3 years, the difference. And also the decreasing the fertility rate. We are below the 1.6 children per woman. We don't have the replacement rate. And it's important to let you know that like another country, we have previous the pandemic, the non-communicable disease was the first causes of death, especially the chronic heart arrest, cancer, and the traffic accident was the leading causes in our country. In the picture, you can see how our pyramid is changing for the next years, and for that, this is a really situation that the country has to handle, because it's important to assume that the increase the life expectancy is a very good outcome of the country, but the country has to assess this outcome and prepare for this greatest change in the dynamic of the population. The next, please. The COVID-19 evolution since in March, like another countries in Latin America, we start in March, and you will see in this graphic how was very slowly increasing the cases, very slowly until August, and then the cases are growing up. And we will see some different strategies that the countries take to control the pandemic in our country. But this is important to let you know that how slowly was increasing in the first weeks, and then we start to growing up the cases of COVID-19 in our country. The next, please. The governance and response in Costa Rica was quite different than the other countries. The most important was the institutional coordination center was led by the decision maker, especially with the Minister of Health, with the technical team and the health risk management at the subnational level, and also start to operate the health operational desk. The national risk management system operates in conjunction with the regional and municipality emergency committees. And these committees are integrate all the institutions and the community working together. And especially with this kind of a strategy at the local level, was started the thematic group. All together joined the response from the local level to the different levels, to the regional, national. The health response concentrates in educational efforts focus on hand washing, use alcohol gel, and keeping physical distance, with the mandatory use of mask or face shield arriving later. Costa Rica did not implement a general lockdown because our law is not allowed to do that. For that, we go to the request of voluntary isolation from the population and impose the vehicle restriction. Next, please. The emphasis was placed in contact tracing and following up the cases. And of course, especially for our social security and the primary care, strengthening to time to the hospital and capacity response. The PCR testing previous focusing mainly on symptomatic patients. The screening was eventually expanded in some community, in vulnerable community, for any person in close contact with a confirmed case became considered a positive case without the need for confirmation. Currently, the significant increase in the cases, the main challenge lies in containing cases to prevent saturation of health services, especially ICU units. The next, please. The key elements for this behavior of the pandemic in Costa Rica, of course, is our health system. And our health system is a unique system that is not fragmented and not segmented system. It's a unique system. We call the Caja Costarricense de Seguro Social, that has the primary healthcare is the base of our system for a long time, more than 30 years, even before the Alma Ata. And with this structure, we can bring the information for all the population. You can see some numbers, how the people was engaged to work together since the communities, and how the family were visiting for biopsychosocial approach. Almost 80% of the household was taking the information by a psychosocial approach, but also the recipes was delivered at home. And of course, all the population was engaged to enroll to services at a local and national networks. Next, please. The social protection and population response was very, very important for the country, especially the institution for the social sector present the routes to follow in addressing the national emergency, focuses on provision the water and water infrastructure, job protection, prevention mechanisms to minors and disability, older people, adults, and the women at the risk of violence. The government bring the protect plans that they try to bring some economic support to the workers through a monetary support that will be carried out the base of the analysis of the priorities on the affected sector to be protected. Also, at the beginning of the COVID-19, the pandemic, there was rebound in the government's positive public perception, but months later, negative opinions were again in a significant number of the population. Next, please. The information and communication is one of the the very important strategy made by the Minister of Health with the daily press, and every day reporting the recenter approach to infographics, virtual training, newsletter, and Facebook to community, and electronic tools to work and registration. The next, please. Some consideration that I want to share with you. The positive act from Costa Rica, of course, is to have a universal health coverage and access based on primary health care. Committed with the health professional was very important. How the professional, our health professional, take this situation as a very opportunity to work together. The population understood and assumed the risk. Use a digital health record which includes information on the family, housing, nominal data, and medical care is very important. And the high coverage of education, primary, and the college is, of course, one of the very important investments from the more than 40 years in the country. Some ideas to improve that we need to improve as a country: expand the number of and type of tests for definition and case and seroprevalence studies, strengthen the risk communication at the community level, carry out research and evaluation to the measure implemented, and keep learning and implementing action according to the new evidence. Next. My final remarks is about the characteristic of the governance in the case of Costa Rica. And I want to highlight how the consultation with the scientific team was important. That is the community based
Sorry, Rocio, sorry to interrupt, but we can't hear you well.
Could you hear me now? I am.
We can't
Could
hear
you
well.
hear me?
Okay, now we can hear you better. Thank you.
Could you hear me? Okay, I have only 2 minutes more. Contribution is very important. The social contribution in the sector of civil society and what is participation governments. The women and social or minority in the tower, women as a decision makers was included the ethnic groups besides. Transparent Minister of Health at the President Office, daily reports with limited information, success or effectiveness indicator. This is, we have to move a little and to do better in the future. And a high degree of leadership and credibility of the health authority, And the decision and local emergency committees will continue technical support by the health expert, especially to work in the communities and the power delegation. That's it, and thank you for your attention. Over.
Thank you, Rocio. We had to shut down your camera. I think you didn't have enough bandwidth. We will end with my very quick presentation, and then we'll have some time, very short time for questions. It's 5 countries, so there's a lot to cover. I'm going to discuss what I call the blind spots in governance in Ecuador's response to COVID. As you can see in this graphic, also borrowed from Financial Times, Ecuador is in second place of the highest mortality death rate in general during the pandemic in the world. So this means that these are deaths that are unaccounted for, not necessarily COVID. We only have 12,000 total COVID deaths, confirmed COVID deaths, but we have more than 2,000 deaths per million people in a country of 17 million people that are unaccounted for, that are in excess compared to 2019. Thank you. Next, please. So we made an emphasis, as you can see, in the difference between a federalist countries such as Brazil and Argentina, and Ecuador, Chile, and Costa Rica, which are a unitary state with a central government that makes the decisions. As you can see, Ecuador is relatively unequal according to its Gini coefficient. Only 40% of the population has health insurance, public health insurance. It is a fragmented and segmented healthcare system that it privileges the publicly insured and privately insured. And we have a recent humanitarian and sanitary crisis with around 350,000 to 500,000 recent Venezuelan migrants and refugees in the country. Next, please. So what happened in Ecuador is similar to Chile. We had a severe political upheaval induced by International Monetary Fund measures that were intended to confront an economic crisis that we have still not been able to overcome, and we're still seeing political and social upheaval in the country. We had a very long national lockdown, up to 2 months of full national lockdown, which was very, very difficult financially, economically, and also mentally and socially. And nevertheless, despite a very early lockdown, we had a quick collapse of hospitals and a high spike in deaths almost immediately from the onset of the pandemic in the country. Next, please. So as you can see, the reports of COVID-19 cases and deaths in Ecuador was very erratic. We had huge backlogs and lags in result reporting. So you can see these spikes are not necessarily sudden spike in cases and deaths, but a spike in reporting. And you can see that throughout the pandemic, and I reported on this very early on, it was erratic from day one, and it continued to be erratic and is still erratic. We really do not know what the real incidence rate is because of this. Next, please. So in the analysis, you saw that Rocio shared how we analyzed the governance characteristics. We did not individually count the characteristics of the governance response. We did a synthesis of the evidence in each individual country. So in Ecuador, what I found is regarding the institutional dimension of governance, that decisions were centralized, were unilateral. They were not discussed with community groups, civil society, and the participation of minorities, whether ethnic or even health minorities, for example, people living with a catastrophic disease, for example. And there were limited intersectoral discussions. Maybe the construction sector was involved in some of the discussions regarding the need for diminishing the restriction measures to give an impulse to the construction sector, but that was really about it. And I also did a policy analysis for another article, so I can confirm this was true. There was also a delegation of responsibilities to the local government, but without any capacity building. Local governments really had to fend for themselves. Next, please. Regarding the operational dimension, Ecuador has an emergency operations committee that would randomly consult with health specialists or including epidemiologists, or especially epidemiologists, but not other health specialists such as health promotion experts. And it was random. We don't know the names of the people who make decisions, and we cannot hold them accountable in Ecuador because of this. Although that's related to informational governance, but still, focusing on the operational dimension. This meant that, again, decisions were very vertical. So this was a vertical operation. It was not horizontally organized. This meant that the line of action was very unclear because only one person knew, and it was the person high up making the decisions. And this also meant that there was limited social protection because the operation was focused on random consultations with health experts. Only the private sector in the construction business. And this automatically was excluding minorities, including vulnerable populations, from the response itself, the operation of the response. Next, please. So regarding the informational governance, which is what intrigued us the most as a research partnership, in the case of Ecuador, was the political use of non-qualified information that was randomly shared, as in, oh, maybe we can use hydroxychloroquine, why not? Or, oh no, the whole country is now immune. These were declarations by the Ministry of Health. Everybody in Ecuador is immune now. You can go out. So this was unqualified information. We have no data on this. Also, there was a change of method in the reporting by the Ministry of Health. So the data that was already very limited, it was difficult to understand how the method of reporting had changed. And this includes what I previously mentioned, not knowing the names of people who were behind any kind of consultation mechanism. So we do not really know, in comparison, for example, to Argentina, where there was a publicly nominated expert group with names and last names. And as I mentioned before, part of the operation issue of having test lags and backlogs in reporting test results is that there is really no information to make decisions. And this is part of the problem of operational governance regarding laboratory capacity, but also part of the information system that reports their results. Next, please. So the lessons we have learned in Ecuador's response are that we have, like in other countries, a systemic governance weakness. We do not have the financial muscle to provide social protection. We are now having a new spike in cases and deaths without the necessary hospital beds. We always said we would prepare for it, and we still do not have hospital capacity. And finally, that there is limited consultation and decision-making. Limited consultation for decision-making, and also that limits accountability. So we are about to wrap the session. We have very few minutes. I will quickly answer the question on community participation. And then I will let Cristina and Osvaldo answer two of the remaining questions. But regarding community participation, how can we improve this? Cristina will allude to this when she talks about the exclusion of the response. But definitely Ecuador has the tools, it has the law. There's a law that protects and guarantees community participation. So it's about enforcing existing legal frameworks. If a country does not have a legal framework, this would be the time to create one, to produce one, to enact a law. And in our case, regardless of the law, we have not been able to do this because we still need to build or rebuild from the previous regime that squashed civil and community participation in Ecuador. We have to rebuild from the ground up, really. That is our only path forward, at least in Ecuador. So I will give the word to Osvaldo, who is going to answer the question that was made about Chile. Osvaldo, go ahead.
Okay. It should not be forgotten that the peaceful end of the dictatorship in Chile was the product of a political negotiation, which explained that for 50 years after democracy was recovered, it followed the same constitution and the same economic model of the dictatorship. Just before the pandemic, citizens massively turned to the streets in an unprecedented social revolt in Chile, demanding change, showing an irreversible break with the past and demanding a new social contract. This forced a political agreement from all sectors, from all the political sectors in Chile, to open up to a constitutional change, and we are now done that. In the recent plebiscite, few weeks ago, 80% of the population vote to approve an assembly for a new constitution, a process that began in April of next year. And I think that is a very good possibility to a new contract with the population, and that improve the governance capacity of our country. Thank you.
Thank you, Osvaldo. So we will end with Cristina, which you have 3 minutes to answer that question.
Thank you, Irene. So there was a question about whether what was the public health information available to the villas in Argentina. And actually, like I said in my presentation, this was mimicked in several countries, was that the information was stay at home, don't leave your house. That was the information. And if you get sick, come to the hospital because we're building hospitals. And in fact, there was a Villa Azul in Buenos Aires that was actually cordoned off. And military trucks went in, bringing water, bringing food. So again, this is another example of how an overly strong institutional governance response bordered on human rights violations. And there was public outcry, not just from the Villa, because obviously a lot of these people work in informal sector and they needed food, they needed to get to their work. But it also bordered on imprisonment, and there was some comments in the international press that this was just, it wasn't an appropriate response. That just cordoning off the slums and doing mass testing and just kind of letting the slums fight it out for themselves was that it really is not a public health, and it's certainly not a COVID response. And again, I think this goes into several questions that have come up about community participation. And this is one of the frameworks for governance that we looked at was, in institutional governance, to what extent are community groups, are vulnerable groups, are, and are everybody else who's not in power contributing to the COVID response, and actually creating a COVID response that's relevant and that's helpful to people who are not in power. And I think that this reflects a lot of the tendency in the region. We've talked a lot today about how Latin America is a very unequal region, and a lot of the power, not just the economic and the financial and the educational power, is concentrated in an elite that's been in power for about 500 years. And the tendency is to ignore groups, ignore indigenous groups, ignore women, and ignore disability groups, and, ignore anyone who's not sort of in that elite power. And, Osvaldo's just talked about the example of Chile, of it took 20, 30 years after dictatorship for the elite to actually give constitutional power back to the people. And, these are steps that Latin America has a rich history of social response and of community uprising. And again, COVID is another, it's another fertile territory. We're going to see community groups standing up, demanding participation. And the more that the political and the economic elite starts listening and actually participating with community groups, the more we're going to see that the COVID response is relevant to places like Villas, to Indigenous people, to people with compromised immune systems. So it's a process. It's, this is something that the whole region is battling with, not just Latin America. North America is also struggling with how do we actually have democratic processes that are representative of the people that we're trying to protect, and how do we make public health to be about the public and not just about a small group of people that have an idea of what others might need.
Thank you, Cristina. Rocio's asking me if she can have 2 quick minutes. Yes, please, Rocio. Thank you.
Thank you. Only one comment about how the communication is crossing the health sector. I think, like in another crisis, it's important the information, in this case about the COVID-19, but also how to respond has to be send the message or take the message from the local, from the regional, and for the national level, and or not only top down. And this is very important because there is another institution working at the local level that they need the information and support the message from the health sector. And this for me is very important. In the case of Costa Rica, we use that we call the table, the thematic tables, and these thematic tables are about different topics with the different stakeholders from the local level to the national level, but also from the national level to the local level. And this kind of how to build the communication and how to share and how to understand how the people are taking the message, if they are doing that they suppose the authorities teach to them. And I think this is very important to working and is an issue always in the crisis time.
Thank you so much, Lucio. Thanks everybody for participating, for being here in the presentation, and thanks to my colleagues. It has been a months of work. We continue to find new data, and please contact us if you have further questions. Thank you again.
Bye.